Good afternoon, everybody. Thanks so much for joining us for the Healthy Transitions Colorado February 2015 webinar. My name is Carrie Frank, and I'm the Director of Communications with Center for Improving Value in Healthcare, or CIVIC. I'm very happy to be here with you guys today as we talk about a really exciting program in the rural space of Colorado, the Improving Communication and Readmissions project through the Colorado Rural Health Center. That is called iCARE, and we're also going to hear from some actual boots on the ground, a critical access hospital in Sedgwick County. The Sedgwick County Health Center folks are here to share what they have been doing with all of you guys. And this is a topic near and dear to my heart because I actually was at the Rural Health Center when this iCARE project was launched. So I'm excited to hear the updates of where it's come since I was last there. But I just want to give you just a little background on Healthy Transitions Colorado. We are a multi-organization collaborative, and we are run by the operating partners. CIVIC is actually the managing partner, but we have operating partners, and they are very important to this work and help drive this work. The Colorado Healthcare Association, Telegen, who's formerly the CFMC, the Colorado Hospital Association, and as one of our speakers today, the Colorado Rural Health Center. Healthy Transitions is a collaborative effort focused on aligning, and we really are trying to accelerate existing efforts to improve transitions of care for Coloradans. So we're trying to bring together all of the things that are happening across the state and really promote and accelerate the work. Our guiding principle is really just to break down the silos of healthcare. We believe that we can foster true community care coordination across facilities, specialties, and practices if we break down some of the barriers that are out there. And we aim to do this by coordinating the tools and the resources and efforts of the many partners across the state. So we really are aiming to keep Coloradans healthy so that they can enjoy more of what our beautiful state has to offer. And the goals for the campaign are threefold. We are wanting to eliminate 8,700 readmissions across the state of Colorado. We also are looking at eliminating over 34,000 days in the hospital, and then also saving Coloradans $80 million in costs. So if you haven't already done so, we'd like to invite you to become a community partner and take the pledge to improve patient care transitions. And you can do that by going to our website, and that's also where you can learn more about the campaign and find those resources and tools. Our website is healthytransitionscolorado.org. So just a couple things before we get started. We do have all of you guys in listen-only mode, and you'll remain muted throughout the entire webinar. We will be using the chat feature available in your lower left-hand corner of your screen to field any questions that you may have and allow comments to be made during the discussion. We probably won't address any of your questions until the very end, but as you have questions, please feel free to put them in the chat box, because I know sometimes it's hard to remember unless you're a good note taker what questions you have. So feel free to be posting those as we go through. And then at the end, we will address all of those questions. So the webinar is being recorded, and we will have this posted on our Healthy Transitions Colorado website so that you can access this information again anytime at no cost. So without further ado, I'm going to get started with the program. We have some exciting presenters here with us today. Nikki Hyde is the Quality Improvement Specialist from the Colorado Rural Health Center. She'll be joining us first, and then we're going to turn things over to Sedgwick County Health Center folks. We have Ashley Maristoka. She is a nurse there and leading the charge for the iCARE program at Sedgwick. In addition, we'll have Michelle News, who is the Director of Nursing, and Janet Coyne, who's the Quality Director at Sedgwick. So they'll be joining us. So Nikki, I'm going to turn things over to you at this point.
Thank you, Carrie. I'm very excited to be presenting on iCARE. I'm actually one of 3 quality improvement specialists that really gets to be out there, I would say, alongside our boots on the ground out in the rural hospitals and communities. And just a little bit of overview about iCARE. There are 3 major goals that we really try and hold true to and aim to move our clinics and hospitals under the auspices of these goals. The first one is improving that communication bilaterally between the clinics and the hospitals. Of course, reduce those readmission rates and improve clinical processes that really contribute to those readmissions, and particularly for heart failure, pneumonia, and diabetic patients that we see so often in the hospitals. An overview and background of iCARE comes from about 2010 is where Colorado Rural Health really took on this program, and to look at why there were, or how to really attack the scrutiny that was taking place nationwide on care transitions and those avoidable readmissions. So they took that portion on and also aligned very nicely with Triple Aim and the patient and quality efforts, patient safety and quality efforts that we're actually having across the state. There's 29 critical access hospitals throughout the state of Colorado, and in 2010, 9 of those hospitals came on board with this project and looking at those 3 overarching goals and looking specifically at heart failure and pneumonia, because those were the 2 most prevalent conditions that were being seen in the critical access hospitals. And since 2010, they knew that Colorado Rural knew that they wanted to expand this program and this project, and the linking piece of this would be those provider-based rural health clinics to really have that focus on that transitions of care and the communication that needed to go along with making that successful. And of course, the clinics looked through the 3 overarching program goals and through the lens of the diabetic patient population that would be the focus within the clinic since 2012. 2012, there was a grant that Colorado Rural Health Center received from CDPHE, which allowed for a partnership with the SECAHEC, the Southeastern Colorado Area Health Centers, that they were able to provide self-management community training and those linkages between the community workers and your public health, and provide that additional health education that the patients need in conjunction with the care that they were receiving in the clinics and the hospitals. So as far as our accomplishments, we are actually feeling like we're gaining some ground. It's taken time, and to really just get the message out there and the mission of why we are, and the purpose of why iCARE, and making that difference within our hospital, the clinics, and the communities. So again, we expanded from 9 critical access hospitals in 2010 to over 20 CAHs and rural hospitals now, or clinics now in 2015. We've seen process improvement with the Pneumovax administration. We're involving the staff now. We're really looking and focusing in on that team-based care model and process ownership, and you'll hear more about that from Ashley, and getting the buy-in from your team, your identified team. We're able to supply or share tools and processes and designs that the clinics and the hospitals are now able to share out with other clinics and hospitals. We have a lot of peer learning opportunities. Data analysis is probably near and dear to my heart the most, because when I came on board here, it was a challenge. It was a real challenge for the clinics and the hospitals to input their data and then extract it and then be able to analyze it. And we're actually seeing them asking the why questions and using their data to tell the story to leadership, and it's making sense with the teams as a whole. We're really focusing more on practicing a systematic approach to improvement. So it's really they're layering on, and that's spreading throughout the facilities. We have Lean Six Sigma that we're able to offer, technical assistance. We have monthly webinars, education. We go out and do our process mapping, whatever technical assistance the clinics and hospital may need. And of course, we have awareness now on a national level. We were able to have storyboards 2011 and 2013 at the IHI National Forum, and then there's been local and national presentations at different conferences and venues throughout the state. The next slide shows you a map of Colorado, and with this map you'll see that the X's are the hospitals, that the blue X's are the hospitals that are participating in iCARE, and the blue circles are the participating clinics. So we really are in the four corners of the state along, and of course along the center portion of the state. We actually, there's three of us, as I said, QI improvement specialists, so I actually have the quadrant of the state that is east of I-70, which provides me that opportunity to walk alongside the Cedric clinic and hospital and really cheer them along with their efforts. Our iCARE program structure has a triangle approach with the team structure at the top, and that's so vitally important. If you don't have that team identified, bought in to do the spread, we're spinning our wheels out there, and I would say that the clinics and the hospitals would say the same. So we really, when we go out yearly to do what we call re-engagement meetings, we actually have that whole team sit in on this, and that would be your hospital folks, your clinic folks, and those are the identified. No clinic, no facility, no hospital are exactly the same, but we have quality directors, we have frontline staff, nursing staff, front office staff that will actually be on these teams. We have found that we really are in need of engagement from providers. Now, Cedric will have a different approach to this, but we're finding that having that peer-to-peer provider support is really adding traction to our efforts of what we're doing. During these engagement meetings, we have the team set a project plan, outline a strategic goal of where they plan to go throughout the year, and some of them achieve those 2 or 3 months in, 6 months in, and then we set another goal. But they are focused and wrapped around the 3 iCARE goals, overarching iCARE goals. And one of those goals actually incorporates how they can work closely between the hospital and clinic, whether that's looking at medication reconciliation or really improving upon their communication when they're discharging that patient and then they're picked up at the clinic side. Our data submission, which I touched on briefly, we now are submitting to QHI. We have all but one of the clinics submitting their data into this benchmarking tool, which is supported by the Kansas Hospital Associations, and this actually gives the hospitals and clinics that opportunity to benchmark against other small facilities, rural facilities throughout the country, and it allows them also that opportunity for timely data reportings, and they can generate graphs off of this, and those of us internally at Colorado Rural Health, then we can just go in and look at the data and have aggregate data right at our fingertips. So it's a very efficient way to capture the data. On the data side of it, our hospitals are collecting 3 measures and any others that they feel would be pertinent to reduce some of those readmissions or what they're seeing most that they need to work on or would be benefit their facility. They're looking at 30-day readmission rates, heart failure discharge instructions, and pneumonia vaccination for individuals over 65. Our clinics look at 13 measures, a cohort of 13 measures, and if that is too cumbersome for them, in the beginning, actually I can say that all of our clinics are collecting all of these measures now, and it's been with a lot of hands-on support from us here in Colorado Rural Health and the very proactive teams in the clinics. So they are able to collect the measures on these or the data on these and then report out and analyze where they really need to make improvement or applaud where they really have strong processes in place that are impacting positive patient care results. This data graph is just showing, and it's an example from 2012 to December of 2014. This looks at our 30-day admissions throughout the hospitals, and this is an aggregate level data that you're seeing here. Our next graph is looking at diabetes. Those are the A1Cs greater than 9. And we're actually doing quite well on that and are seeing some improvement across the board with the clinics throughout the state that are participating in iCARE. Our last slide is our contact information. If any of you have particular questions, Jen Dunn, our Director of Programs, is available. Caleb St. Murphy is also available. He's on the cost side. He's our program manager for the hospitals, and then Sarah Leahy is our workforce and clinic program manager. And without further ado, I'm so excited. I am partial. I love this hospital and clinic and their staff and all the great work that they're doing. So I'm going to turn it over to you, Ashley, and your team out there.
Ashley, are you on the line? We're not hearing you.
Can you hear me now?
Oh, that's better.
Okay, can you hear me now?
Oh, that's much better.
Perfect. Sorry, I muted myself. So. Hi, everyone. My name is Ashley Marostica. I'm an RN, and I'm the discharge planner out here in Sedgwick County Health Center in Julesburg. And Caleb and Nikki and Jen asked me to talk today, so bear with me. If you guys were at the presentation in Colorado Springs, this is the same one from that. Below is my slideshow, and we're going to skip right to slide number 36, and then we'll kind of go back from there. So if you guys want to bear with me, I'm going to slide this. The first several slides are just an introduction and background history. So just so you know, in the past, everybody has problems with MedRec, discharge planning, and you try, magnets on the wall, you try like medication cards, and you have a really hard time, getting hospital medications to match home medications, and then when patients come back to the clinic, it's a disaster. So our first couple slides, you can read through them if you want at a later time, but it just kind of talks about our history in the making and how we got to the point we're at. So in 2011 to current, we started our Project Red tracking, and this was done with Janet Coyne. She's our quality director. And we're just tracking readmissions within 30 days. Our goal was to prevent 30-day readmissions. We wanted to start providing better education and more elaborate discharge interventions. So we used an Excel sheet in doing so, and then we reported the data to CHA. We also issued patient evaluations, and then we provided follow-up phone calls within 24 to 72 hours of discharge. And from there, we were making follow-up appointments and noting if they needed oxygen or home health or anything that wasn't taken care of at discharge, especially if it landed over a weekend. And just so you guys know, I have all these attachments. I don't know if they'll be able to be seen or not, but I have like all the documents attached that you guys are more than welcome to have access to and use. They're just templates. So in 2004, our Project Red, we also started a transition care model, and our goal was to evaluate inpatients on day of admission and give them a score in regards to risk of a readmission. And so you can kind of just see we've just started multiple tools to address readmissions at the time of admission. So here's some more information about it, but we're going to kind of go past that. And we're going to keep skipping. And EMR came along, and we had major problems like everybody else did. Okay, so in November of 2013, our discharge, we started creating yellow discharge packets, and Caleb and Nikki came up with more elaborate names for this, like the formerly known as the Comprehensive Personal Health Packet, which, okay, yellow packet's way easier. But we piloted this in November of 13, and then in February of 14 we went full blown with it. I went on maternity leave in November, and then I came back in February when we kind of picked up the pieces and went onward. And it says sample packet will be available, but I will get this information to everybody. So what we did is we have a yellow packet. It's just a yellow folder. And initial packets were developed in 2013, and then we piloted it till the end of the year. Our initial kickoff was January 27th of 14. The packets were located on a shared network folder all deserving staff had access to, and it can be started by one nurse and finished by another nurse. It continued improving. We continued improving usage and results since implementation. Engagement of patient, family, and key caregivers hasn't greatly improved. And then due to a small patient denominator, our results may not correctly reflect our success with this project. However, as an entire interdisciplinary team, we are seeing the fruits of our labor pay off. And then patient education and family education has also adapted. So it's been really nice. So we have this yellow folder, obviously, and inside of it, it has like the patient's name and the cell phone contact, and the date of admission and date of discharge, and where they were discharged to and where they admitted from. Their admitting diagnosis, their past medical history, past surgical histories, allergies, code status, vital signs, and we're noting like weight of CHFers before or at admission and discharge. Their pharmacy choice, medical equipment, therapies offered such as PT, OT, and speech, plan of care follow-up, contact information for other interdisciplinary outlets, immunization status for flu and pneumococcal, smoking history, advanced directives, medication reconciliation, and teach back. And then on the front of the chart we had a sticker we just put on the front that they can slap a label on, and then inside the folder has another checklist. So before the patient's actually sent home, we can check off and make sure that we covered everything. And so what we're asking the patients to do is bring back this yellow folder with their discharge packet inside, and then they're bringing it back to clinic appointments or to specialty appointments, and it's just kind of nice because they can see all this and know exactly what meds they were sent home on, and they don't have to repeat labs, or like a ultrasound was done on Monday, there's no sense to repeat it at a different facility a week later if nothing's changed. So we definitely had some difficulties getting this packet going. Staff engagement, adaptation to change, starting the discharge process at the time of admissions, asking questions, discharge paperwork to go along with this. Okay, that's another subject. But yeah, every place has problems getting staff engaged, and we're still working on it. I'm kind of the champion behind it, but all the nurses right now are picking it up. Like I'll start it, they'll finish it, or vice versa. Monday through Friday I work, so I can definitely get things going, but it's just really nice. And like I say, it's located on a P drive, and so everybody that has access to it should have access to it. And the doctors can pull it up while they're sitting in their desk. And if the patient's readmitted or comes back to the ER, we can pull up that packet and we can kind of go from there. And they're also bringing it back, like I say, to ER in the clinic, and so we don't have to go searching or question anything. Upon discharge too, as Nikki was talking, we do just a lot of checks, and Caleb and Nikki created a checklist kind of for me. But it's a daily discharge note we're doing on patients, a daily utilization review note. We're doing the transition care model for all patients, like I said. We're doing a daily checklist. We're doing daily update of discharge packets. We're doing mail-out evaluations to patients like post discharge and asking questions again, and then we're doing we're stamping envelopes ahead of time and putting them in there so they don't have to pay for postage. We're doing our follow-up phone call, and then we're doing the Excel tracking form. And all these forms are available for everyone to see. And so from our medication reconciliation discharge at the hospital form, I am typing that up into a different clinic med list and putting it in the director, the clinic director's box. And she is taking it and giving it to the nurse when the patient's coming to be seen next. So the medications from hospital are already on a new template that matches the clinic chart, and so they should be identical. And we're doing trade and generic names, because there's some discrepancies between those two. And we're doing, just as much as we can to help eliminate errors. So let's see. Also, at the time of discharge, when I either call them or we make appointments before they leave, in our resource manager through our clinic, we're making appointments and we're highlighting them in orange, so it's like a VIP status, and we're putting follow-up from hospital. Patient was seen was an inpatient from 2/11 to 2/13. Has labs prior to the appointment, and we're making it orange. So if that patient cancels or something, we're like alerted to the fact that we need to make sure it's a rescheduled, and also to look for that med list and make sure we're checking off the right meds, and especially with Coumadin levels, making sure we have the right dosage noted. Overall, we have been noting great success. We feel like we are now closing the loop. This has been the best medication reconciliation process we have had yet, and we will continue to look, evaluate, and make necessary changes. One of the changes that came about this year was just our discharge template, which you guys will have access to. There's been some glitches with the medication boxes, and when there's extra information, the boxes are not flowing over correctly. So we're just going to fix a few things just in the Word document. But that's about it. And if you have any questions, please let me know, and I'll see if there's a way. Nikki, do you know there's a way I can pull up those documents so everybody can see them?
Unfortunately, right now we're not set up
That's
those
okay.
documents, but if you email them to Civic, we'll put it on the Healthy Transitions Colorado website,
Sure.
Along with the recordings, so everybody has access to them.
Sure. Yeah. And I'm sorry, I spent way more time on those documents than the PowerPoint. And basically, when you guys are able to look at all this stuff, I used 2 patients all the way throughout all my examples, so it kind of makes sense on everything we do. I use an inpatient, and I also use an OB, and so you can see the discharge packet completed. You can see the clinic med list that correlates to that one. You can see the Excel document that correlates to each of them, and like the follow-up phone call. So it's just the same 2 patients throughout. And it definitely is like good to look, use. And there's actually there's like blank templates and there's filled-in templates. So feel free to use them, tweak them, however best you want to use them if you like them. We did just get a colored print at our nurses station, so our nurses are quite thrilled. We have a system to color code like new medications, as needed medications, stopped medications, and like indications like we gave education, or like with like Xarelto or different medications post-surgical. They're 30 days, and we have like stop dates on different ones, and like prednisone as well. So does anybody have any questions? You can either type in the box, or you can ask Nikki at the end of this.
Yeah, we're just taking, thank you so much. We're just taking questions through the chat box. So if you guys have a question for either Nikki at the Rural Health Center, or if you would like to ask Ashley a question from Sedgwick, then just type it into the chat box in the lower left-hand side. That would be great. We'll take a minute to see if we have any questions that are going to come up. So Ashley, you may have mentioned this, but what kind of results have you been seeing so far? Do you guys have any data that's shown over I know you've been working on transitions for a long time now. Have you, what areas have you seen improvements? And I know it's kind of slow when you have small numbers that you're seeing in the rural areas, but what have you seen as far as any data that has shown improvement so far?
Definitely, we've reduced our readmissions, which is a plus. And actually, lately, our census, we've actually been full here quite a bit. I don't know if it's just because of the influenza and pneumonia or what's going on, but we are running full here. The last 2 months, it's just been absolute chaos here. So our numbers have actually been a lot better than in the past. Our average census has not just been 2. We've been steadily like 6 to 8 constantly. But definitely with these packets, the things we've seen, is just good continuity of care between hospital and clinic and specialty clinics. We've seen medication education done, and patients actually know what they're on and when they're supposed to take it and what they're taking it for, and what side effects to look for, signs and symptoms they should be calling us back for. So we're definitely seeing, medication reconciliation has improved immensely. And right now our system that we have, going from hospital to clinic has been working out fabulous. Like I say, I type up another list that's just like the one we sent home, and it fits the clinic charts, and I'm going through and marking them. And like I said, I'm giving them to Deb, the clinic manager, and she's putting them on. She's giving them to the nurse who's going to be seeing the patient, and she's noting this in the hospital manager. So we have a good systematic approach going right now for that. And it's just nice too because we know what pharmacy now the patient we should be calling about, or we know the flu and pneumonia status is, so we know if they need a booster shot or if they need the flu shot or just stuff like that. We know what their last discharge height and weight were. We know what their readmission weight is, and we can just kind of gauge their CHF and stuff like that, or we know what medications they went home on and switched up, or what may have worked better, what didn't work. So we're just seeing a lot more education, than we have in the past. And we can just basically tweak these charts. So like if you do unfortunately have readmissions, which does happen, you've got cancer patients or infected patients, you can just tweak their discharge paperwork and make it very complete and know what you did last time. And so.
Ashley, could you talk about a little bit how, when it's time for that patient to be discharged from the hospital, how that appointment then is made in the clinic and that follow through?
Sure. So I don't know what you guys all have for like how your hospital and your clinic are tied. In the past, we used to just call down front to our clinic and make the appointment. But now all of the nurses and our administrator, our directors have access to what's called Resource Manager. And what we do is we look and see if the doctor says, yes, I want to see this patient back in 5 days. We calculate whether, if they were being discharged home today, we would look at like probably a Monday appointment, or something like that. But we would look and see who their primary doctor is if they're available. And what we do is we just look and say, okay, Dr. Aguirre's got an opening at 3:30 today, and we're able to make that appointment ourselves from our computer. And so before they go home, most of the times they actually have an appointment made. And what we do is we put 3:30, we type in the patient's name, we put reason for follow-up, we put follow-up hospital, we make it 15 or 30 minutes, and then in the comment section we put follow-up from inpatient stay, patient has lab, whatever. And then we save it, and then we change the color coding on it from just a standard appointment to a VIP, which changes it to orange, so it kind of flags the girls down front. And then we leave it like that, and then I put in the comment section med list given to Deb Nail, and then from there Deb Nail will type med list given to Linda Eckhout, Dr. Aguirre's nurse on 2/21 or 2/22, whatever. And then so it's just like a record of like I filled out the med list from discharge, I gave it to Deb, and then Deb gave it to Linda. So we kind of have a tracking system of in case anything goes wrong or proof that we did this. Also, if the patient is discharged on a weekend and for some reason the nurse doesn't make an appointment or something, I always do a follow-up phone call, like I say, within 1 to 3 days from discharge, and I will actually look and see if there's been an appointment made from their discharge packet, or I'll go in Resource Manager and check it out. And then when I call them, I'll either say, hey, John, it looks like you're supposed to see Dr. Aguirre on Monday at 3:30 for your follow-up, and you've got labs, so come 30 minutes early. Or I'll say, it looks like you're supposed to see Dr. Aguirre in 5 days from discharge. Can I go ahead and make that appointment for you right now? And then I kind of offer him like what Dr. Aguirre's availability is, and if he doesn't have availability, I say, is there somebody else you would be able to see? And then I just kind of go from there making appointments. So it's been helpful to have the nursing staff be able to make appointments. Otherwise, if you leave it for the patient to make appointments, they may not. Does that answer that?
No, that was great. One other question I think that I'd like you to speak to is, and I know we've talked about this because when you went on maternity leave, the project wasn't, I think it was well on its way, but it wasn't embedded in what you were doing. Can you speak to the progress that you've made as far as feeling comfortable? Say tomorrow you had to be out for 3 weeks or a month or so. what that would look
Sure.
like for your facility.
Sure. Like I talked initially, we kind of piloted it in November, and we had a couple discharge packets that got done, but it really wasn't embedded to the nurses. It was just easier to do a quick print-off list. But now I feel that if I were to leave tomorrow, which I would not complain about at all, I think that it would this project would just continue like it has been. The nurses on the floor will do a great job. Both of my bosses, the directors of nursing, can pick up and do it easily. They're all kind of educated that it's there, and I don't think not everybody likes it. It's a little extra work. You have to go above and beyond, and a lot of people aren't. Some of the older nurses aren't liking Microsoft Word, but they're learning. They're doing a great job. And I'm anal. You can ask anybody. I've got a little OCD, but I like my packets color-coded. I like them the same font throughout. I like the same size of font. I like to highlight, emphasize different things. But the packets would be done, and I would, not to my crazy colorness, but they would be done, and they would be definitely functionable for the next admission or whatever we needed to use them for. The next physician coming on for the weekend, and whether it's a locum, they're easy to obtain and use and work with.
Thank you.
Yeah.
Thank you.
I have just one more question for you too, Ashley.
Sure.
So what happens when your patients might travel outside of your community? Because I think your system is amazing internally. So what happens if you have to send a patient, unfortunately, to Denver for care?
Like if we transfer out?
Yeah. How do you translate the information that you guys currently have?
Okay. Yeah, so like I say, we start these packets on admission. So regardless if we ship you out or not, we usually have a packet started. What it does is it's nice. We actually just had this happen. We shipped out a lady when I came to work on, I believe it was Monday. She was admitted Sunday night. We started a packet Monday when we got there. She got very ill. We ended up shipping her by air in the lovely snowstorm that came through. And we had already started the packet, so it wasn't completed packet. It wasn't, it didn't have follow-up appointments, but it had enough of her meds, home meds, and past medical and stuff that we just printed it off, and we sent it with the patient along with our other EMR notes, like the doctor's H&P and, smoking history and lab execution, radiology execution. So it's just another piece that really helps that discharge planner up at university or Poudre Valley or wherever they're going, understand what her home meds are, because sometimes the way the EMR prints out, which I'm sure you guys see it, it's ugly. It's very ugly. You're like, okay, home meds versus normal meds versus new start meds versus I don't know meds. So it just kind of gives them a clue exactly what she came in on, and here's the medications we've given her, and I don't know, it's up to your discretion when you send her home what you're going to put her on. So.
Great. And are you guys connected through HIE, through Corio or anything yet? Or
Carla's our CFO is working on that right now. When we were out there in Colorado Springs this last time, we talked about Corio and stuff like that. So we've been able to transmit with one hospital our EMR information. So we're working on it.
Great.
Yeah.
Well, very cool. I don't think we have any other questions on in the chat box, but it's been very helpful. And again, we'll get this information posted within a week or so up onto our Healthy Transitions Colorado website. And if you guys want access to any of this information earlier, feel free to contact Civic.
Yep, and you can email me too, you guys. I'll be glad to just email you all this stuff. And when you see what I email you, my presentation will make a lot more sense. So I apologize. I was hoping I could bring up my Word documents and all my discharge packets so you could actually see. But feel free to email me, and I'll shoot you everything I have. So thank you.
Thank you again. Everybody have a great day, and we look forward to seeing everybody on the next webinar, which we'll send out as soon as we have all the information. So enjoy the rest of your afternoon. Thanks again to our presenters. We appreciate it.